Dr. Mahmoud, can you raise okay, thank you.
So the outline of the talk, I'll talk about who should we test, especially if we have limited testing capabilities. I'll talk about some of the presenting symptoms, and some of that was covered already. We'll talk about the role of transmission of the asymptomatic patient, and it seems that was one of the real challenges in controlling community spread in a lot of areas. Some of the imaging and the role of CT scan, and that also has been covered some. We'll talk about the abnormal labs that can help us identify patients and stratify their risk. And we'll talk about the actual testing, the PCR and the humoral immunity. So the CDC and the Infectious Disease Society of America came with some guidelines to help with the testing, especially early when the disease was spreading slowly. Now it's a pandemic, so it is one of the most common things we need to rule out in patients presenting with respiratory symptoms, but we need to still use our judgment to determine if the patient's symptoms and signs of presentation are compatible with the COVID-19. And should we test those patients or not? And again, this is if you don't have testing capabilities where you can test more people. Obviously, you need to consider other factors, especially depending on the community spread in your area. We still see some flu activity in our area here in Tennessee. Other respiratory infections can be also causing similar presentation early on. So depending on where you practice, you may need to do something else other than just the COVID-19 initial. Because of the limited testing capabilities in many places, even here in the United States, until just 2 weeks ago, where we had more testing capabilities, they set some priorities for testing, and they gave the priority to the patients presenting at the hospitals with respiratory infections. And the idea is to identify those patients early, put them in isolation, and protect others from getting nosocomial healthcare infections. And obviously, we need to identify healthcare workers who present with symptoms or got exposed to prevent them from spreading it to other people. The second priority is the patients at risk, and those are the ones who are elderly, as mentioned by my previous colleagues, people living in long-term care facilities like nursing homes or skilled facilities, patients with comorbidities, and first responders presenting with symptoms. The third priority for testing is, especially if you are realizing there's increasing hospital spread from the surrounding community, you need to test your symptomatic patients, even with mild symptoms, and communities with high COVID hospitalization. You need to check with first responders and healthcare workers, individuals who do not meet the above criteria, but they still have symptoms. And if you have enough capabilities of testing, then you can even test the individuals without symptoms. And we'll talk about the importance of the asymptomatic carriers in spreading this type of pandemic. So identifying patient is challenging because the presenting symptoms, as some of my colleagues, especially from China, alluded to, it's a variable presentation. Majority will have fevers. Some like case series had almost 99% presenting with fevers. Coughing was the second common presentation, which like constituted 60 to 80% of the cases. Myalgias, almost 40%. Fatigue, more than 1/3. Interestingly, GI presentation was described with different percentages in different studies, so it ranged from 3 to 10%. And we need to remember something important, that not all patients can present with symptoms when they are infectious. This is a timeline exposure of an index case with an asymptomatic COVID infection. And this is a patient who visited Germany, had some business meetings with 2 or 3 other people, and then went back to China. After that, his symptoms started, and he had a positive PCR. And you can say You can see here that the people got exposed and they start having symptoms. And even the people getting exposure to the contact of number one, patient one, also had the infection. So from this timeline, we can tell that transmission unfortunately happens even before symptoms started, which makes it even difficult for us to identify who needs to be tested and who needs to be isolated. This other big cohort of 181 confirmed cases shows that patients after exposure, they still can be infectious until they have the symptoms. And there is some patients who don't even have symptoms. And again, these are the patients who can transmit in the community because they are asymptomatic. After identifying the patient with the presentation, common blood work that we do for most of our patients is helpful. From big studies coming out from China, this is from Juan et al. This was published in the New England Journal of Medicine. They described almost 1,100 patients, and they found out that something like lymphopenia was common in the majority of patients, and that might be something helpful. It's about 83% of the ones who had the blood tested, and that was obviously more common in the severe cases compared to the non-severe ones. The other finding that was common in 1/3 of the patient was the thrombocytopenia, which is a platelet count less than 1,500. Normal white count was also the common presentation for most of those patients. When we talk about inflammatory markers, majority of the patients, 60% of them had elevated C-reactive protein, obviously more common with the severe cases. Procalcitonin, which is a marker that's very helpful in distinguishing viral from bacterial infection, was not elevated. So if we are seeing a patient with symptoms who had abnormal blood work, abnormal imaging, we are worried if this is bacterial versus viral initially until we get the results. Something like a procalcitonin, if it comes back in real time, may be helpful in distinguishing some of those cases. Another marker, the LDH, was found to be elevated, especially in the severe cases. And D-dimer was found to be elevated in almost 60% of the cases of severe COVID-19 infections. Going to the radiological findings, and this I think was covered by our professors from China. Initially, abnormalities of X-ray was common, almost 60% of the patients, obviously more seen with the patients with severe symptoms. And it has distinctive bilateral patchy shadowing, and that's important to identify early. But the CT was the one that has really good value as an addition to the diagnosis and pointing towards this COVID-19 in the areas where there is community spread or where it's now everywhere. 86% of the time, they found abnormal CT scan. And this is obviously more common if you have severe disease. And again, bilateral shadowing was almost found in 50% of the cases. So we are looking at abnormal CT scan with bilateral shadowing. It could be ground glass opacity. It could be interstitial abnormalities. And there's a study from Chi that was just published in The Lancet last week, comparing CT abnormalities even for asymptomatic patients in the subclinical patients. And that was in 81 patients, they were admitted to the hospital. They looked at 4 groups, one that has subclinical patients, 2 had scans less than 1 week after symptoms, 3 had CT after 1 week to 2 weeks. Then the group 4 was the one that had the CT 2 weeks to 3 weeks after symptoms. And interestingly, if you look at this, the subclinical group 1, almost 90% of them had ground glass opacities on their CT scans. And with time, you are seeing more of the consolidation, more of the mixed reticulonodular pattern. And this is important if we are looking at serial CT. And I think one of our colleagues, Dr. Lee, showed what happens to those CTs with time. And again, this is how it presents with bilateral involvement. You can see the consolidation with the spread with time. And fortunately, patients who survive have improvement in the CT scan after they recover. One of the questions that we looked at from the Q&A just before I started was about the role of the CT testing in diagnosing COVID-19. And this is a report of almost 1,000 patients from China looking at the positive CT scan with consensus of two radiologists saying this is most likely a CT scan of a COVID-19 patient because of the settings. It has a very high sensitivity. And this was compared to a specificity, which is a little bit limiting because as we just heard from our colleagues that mycoplasma can have similar presentation early on. Other viral infection, RSV, parainfluenza can have similar presentation, but the sensitivity is very high, it's in the high 95, 97%. So having the CT, if the PCR is gonna take a while, and unfortunately in our area, the turnaround time for the PCR still is 3 to 4 days. So this CT scan early may help identify those patients and offer them some of the available treatments if we could do that. Obviously, the clinical symptoms and clinical signs vary at the time of the presentation and the stage we are seeing the patients. The lymphopenia and the increased D-dimer can be early, but something as serious as the ARDS and the shock with SARS and cardiac failure. We have the cytokine storm, and those are the patients who will have the increased levels of IL-6. The D-dimer is high. We have the troponin elevation. So depending on where the patient is at the spectrum, how we are going to interpret and explain some of their laboratory findings. Obviously, there is risk factors for high morbidity and mortality. So if we identify this early, those are the patients who will benefit from like maybe introduction of some of those treatment options that I think some of my colleagues will touch base on. The testing for the actual virus, as Dr. Raban and other colleagues talked about, the PCR, the CDC recommends collecting and testing the upper respiratory specimens, especially the nasopharyngeal swab. And obviously there is some limitation in the testing because of the risk of aerosolization and the availability of PPE in some areas. So fortunately, there's a newer test that was just approved that can be self-done where there is no risk for the healthcare provider getting exposed. If the collection of the nasopharyngeal swab is not possible, then you can have oropharyngeal swabs, or you can do the mid-turbinate nasal swabs. Obviously, some of those other swabs have limitation in the sensitivity, as we had seen from our colleagues, where the sensitivity varies depending on what type of specimen are we sending, and obviously the timing of the swabbing itself, because depending on where you are in the incubation period or the symptomatology, the swab false positive or false negative percentages change. They've been described like 10 to 30% false negative cases in some series. Unfortunately, there is no prediction of the value and accuracy of the testing so far. And the more we know about the testing, the more standardization we'll have. But if the initial test is negative,
3 minutes? 3 minutes.
If the initial testing is negative, then we need to assess if the patient is truly at risk or not. And if they are, we need to continue to treat them as COVID. And there has been publications proving that there is differences in patients at the time of testing, and something like a bronchoalveolar lavage having very high sensitivity and 95 or 93% positivity compared to sputum, which is less, 72, or nasal swabs. So the site of collection is important. The other thing that we have testing for, fortunately, and is becoming more commercial now, is the humoral response. And this will test the IgM, the IgG, and the IgA antibody detection. The positive rate is high, and this usually shows up around 4 to 5 days for the IgM, around 85%, and something like 78% for the IgG. This, if we couple it with the PCR, it will have very high sensitivity, up to 98% in the positive detection. So maybe combining both testing in patients who are at risk is helpful. And this is a brief comparison between the PCR and the IgM IgG. It is shorter. You don't have to have special handling. It can be done at point of care, and the results are faster. It's like 15 minutes versus more than 1 hour. To conclude, we need to remember that this is a pandemic, it's everywhere, so we need to still entertain clinical judgment in identifying patients who need to be tested and isolated and treated for COVID-19. We need to always remember the role of the asymptomatic patients in transmission, and obviously test the WHO mandate. If you have the capabilities, will identify a lot of those patients and try to identify them, meaning isolating them early. We need to set some priorities for testing if the test is not available, depending on the resources. We need to screen for the cytokine storm in some patients to identify who's at risk of severe complications and higher mortality. And fortunately, with the improvement in testing, the human response to SARS-CoV-2 can aid in the diagnosis of COVID-19, including those subclinical cases. Thank you much for your attention.
Thank you, Dr. Mahmoud, for the nice presentation. Now we will take some questions from the audience.